Up next, Steven Nissen and Dr. Philip Schauer, Chief of Minimally Invasive General Surgery and Director of the Cleveland Clinic Bariatric and Metabolic Institute in Cleveland, discuss STAMPEDE, bariatric surgery options evaluated in search for a diabetes cure.
And Dr. Schauer, your study got a lot of attention today. Why did you do this randomized control trial?
Well, Steve, for probably about 2 decades now, observational studies have shown that bariatric surgery can dramatically improve your blood sugar. But so far, there's yet to be a carefully done randomized trial to address it specifically, comparing surgery with a good medical control group.
Yes, and that's what you set out to do. This is not an easy trial.
No, it was challenging. The recruitment took longer than we thought. But we had to find patients, Steve, that would be willing to flip a coin and either go with medical treatment or 2 surgical options.
So what did the people you randomized look like? How long they had diabetes? What were their ages like? How obese were they?
Well, the inclusion criteria, they had to have diabetes with an A1C greater than 7. They had to have a BMI between 27 and 43. So we're actually targeting patients with milder obesity, BMI below 35. And they had to have an age between 20 and 60. Now, what we got were patients that had, frankly, poorly controlled diabetes. The average patient had diabetes for more than 8 years. The mean A1C was around 9. The average BMI was around 36. And many of them had the beginnings of secondary complications such as retinopathy and nephropathy.
And something else you did in the surgical patients I'm aware is you actually biopsied the liver and found some very interesting things, didn't you?
Yes, we did. We were quite surprised. Some 60% had NASH. They had non-alcoholic steatohepatitis in this group.
Now the leading cause of liver transplantation in America. So,
that's right.
So these are people really headed for trouble.
Yeah, so these folks, they all had, overwhelming metabolic disease. 95% met the diagnosis for metabolic syndrome, and they had a myriad number of other comorbidities such as sleep apnea and so forth.
Now everybody got intensive medical therapy.
That's right.
And how was that managed?
That was managed by Dr. Sangeeta Kashyap, who is a co-investigator. She's a trained endocrinologist. All the patients got standard American Diabetes Association therapy, which includes, diet, counseling, and exercise. And on top of that, the intent was to drive them to an A1C of 6% or less. So Dr. Kashyap was able to use some of the more potent, newer agents such as GLP-1 agonists, insulin sensitizers, and of course insulin.
And those were used in all 3 treatment groups.
That's right. All treatment groups were started out with intense medical therapy. And of course, in the medical group, as you might imagine, the tendency was to increase the drug load, and we saw just the opposite with surgery.
You studied 2 surgical operations. Could you tell us what they were?
Absolutely, yeah. These are the 2 most common bariatric operations. Now, we like to use the term metabolic surgery as opposed to bariatric because we know that these operations have independent metabolic effects aside from weight loss. So gastric bypass, the most common procedure, and then sleeve gastrectomy. Now, sleeve gastrectomy involves simply reducing the gastric volume. We actually staple the stomach and remove about 70 to 80%, leaving a very narrow tubular stomach. With the other procedure, gastric bypass, it's even a more aggressive stomach reduction, leaving about a 15 to 20 ml pouch, about the size of a golf ball, actually. And then we divide the intestines and we connect the jejunum up to that pouch, and we reconnect the proximal end of the jejunum back to the intestines. Thusly, we're bypassing the stomach and duodenum and upper jejunum.
Now, what happened to people in the medical and surgical groups? Were there differences?
Yeah, so at 12 months, we evaluated glycemic control, the A1C, and of course, the primary endpoint was percent of patients that reach A1C of 6% or less. So 42% of the gastric bypass patients met that target, 37% of the sleeve gastrectomy patients met that target, and only 12% of the medical group met that target.
But having read your paper, in fact, that kind of understates the differences because those people that didn't get to 6% in the surgical groups got pretty close, and they got there with not much in the way of medications. What happened to use of diabetes medications in the surgical groups?
Yeah, it was quite remarkable. Of the 42% that actually got to normal blood sugar, A1C of 6 or less, none of them required any anti-diabetic medication, including insulin. And about 50% of the patients in all three groups were on insulin prior to starting the study. And even those, as you said, that didn't reach the A1C of 6 target, they got much better. In fact, overwhelming percentage of the surgical patients got to A1C of 7 or less, which are the ADA guidelines.
Is this a cure for diabetes, bariatric surgery?
Well, surgeons love the word cure. I'm a surgeon, but I must say scientifically it's probably not accurate. I mean, I think we can say we put them into remission. In STAMPEDE study, we intend to follow them, for at least a 4-year extension to see how many remain in remission.
Were there other metabolic benefits other than just controlling blood sugar?
Absolutely. Virtually all the metabolic conditions were evaluated: blood pressure, lipids, and even chronic inflammatory state. We did find that HDL, we're a little surprised to see a very significant increase, about 28%. And as you know, my understanding, it's difficult for a cardiologist to improve HDL.
Very hard. 28% is a lot.
Yeah, and the medical group had just a modest increase of about 10%. And we also saw about a 40% reduction in the triglycerides after surgery. You had a very modest reduction after a medical treatment.
CRP?
CRP, yes. We evaluated high sensitivity CRP, and we found 80% reduction, which I understand is quite a large reduction.
It's really unprecedented, actually, in our literature, certainly to see that degree of reduction. With drugs, we certainly don't get an 80% reduction. So that's very dramatic.
Right, and the medical group got about 30% reduction as well. And of course, one of the biggest changes, not surprising, was weight loss.
Yes.
With the surgical group, on average, they lost about 60 pounds, 25 to 30 kilograms. Their body mass index dropped from 36 to just about normal, 26. Where in the medical group, they did have some weight loss, and we were actually very happy to see that because they were on insulin and other weight-gaining drugs, and so there's about a 5-kilogram weight loss in the medical group.
Very good. Now, I understand that there are some challenges in getting reimbursement for patients for these procedures. Do you anticipate that having a randomized controlled trial like this will change things?
Well, I hope so. I mean, we now have some rigorous scientific evidence, and there's another study that's coming out very soon, and maybe a couple others later this year, that are going to add more weight to this notion of metabolic surgery being a specific treatment for diabetes. But Steve, even for our patients who have severe obesity, we're talking about folks that are 300, 400, 500 pounds, we turn them away because they have no insurance coverage. There are still insurance today that will not cover bariatric surgery for any reason. They treat it as though it was cosmetic, or purely elective, non-essential surgery.
What's the next step for you and your team? Where do you go from here?
Follow these patients in our hope that we can keep them all, in the study so we have significant power to show differences. We're excited about some mechanistic studies. We're intrigued by how rapidly the diabetes is improved and the other mechanisms, and there's a whole slew of hypotheses about gut hormones that are revved up after surgery. So we do have studies coming out in the near future that will specifically address mechanisms.
Well, thank you very much for bringing us up to date on what is going to be a much talked about study, STAMPEDE. Dr. Phil Schauer, I'm Dr. Steve Nissen. Thank you.
Thanks a lot, Steve.